Hello, I'm Dr. John Iskander. Welcome to CDC Beyond the Data. I'm here today with Dr. Mishka Terplan, professor of obstetrics, gynecology, and psychiatry at Virginia Commonwealth University. Thank you for joining us today, Dr. Terplan.
Thank you for having me.
So the first thing I'd like to get out of the way is I think people tuning in to hear about opioid use disorders in women may wonder why two men are conducting this interview. I know this is, first of all, I think it's a topic really that impacts all of us on a personal or professional level. And this is actually something you've devoted a great deal of your career to researching and providing clinical care for.
Yeah, as an obstetrician gynecologist, which is my primary training, I'm trained in the care of women. And I think it's important that actually we don't separate that out, and that gender care is across all health divisions, that men talk about it and women talk about it and everyone talk about it.
All right, so opioid use disorders in women, in general terms, what is the scope of the problem that we are facing?
Well, we're in the midst of an opioid epidemic that has multiple related parts to it. There's an epidemic of overprescribing, there's an epidemic of misuse, there's an epidemic of addiction to opioids, and there's an epidemic of overdose and overdose death. Within each of those categories, we see gender differences. And in fact, recently, the rate of overdose death rates for women exceed that of men. I think it's 400% increase in women deaths and 250 or so for men, both of which are way too high, but increasing more rapidly among women.
So I think many in our audience, they may hear the term opioids and they may have heard the most coverage or the most information about misuse and overprescribing of prescription opioids, but that's only one aspect of the epidemic. What is sort of the fuller scope of substances that we're talking about here?
So you're asking about not just opioids, but other substances or other types of opioids?
More broadly, when we use that term opioids, what are we talking about?
The term opioid means really something that binds to the opioid receptor, and it can be synthetic or it can be derived from the opium poppy, and it can be utilized, prescribed for pain medication. It can be misused. People can purchase some of those same pills on the streets and develop addiction to them, and it can also mean heroin. Increasingly, it also includes what we call other synthetic opioids, such as fentanyl and carfentanil, which are substances with medical use, but that are being manufactured illicitly and are entering into the drug stream. So today, if someone were to purchase heroin on the street, it's very different from what their heroin was 10 years ago. And there's an increasing concentration of fentanyl and other synthetics within that. And the danger is that fentanyl in particular is 20 to 200 times more potent than heroin. And so the likelihood of, when you use it, of having used an excessive amount and overdosing from that is higher.
So a very broad spectrum of types of misuse. Mm-hmm. Biologically, are there factors that make women more susceptible to opioids?
Well, we know that the difference really that you're asking is, what is the difference sort of between men and women? And one difference is the reproductive capacity, the difference in presence of certain reproductive organs, the menstrual cycle, et cetera. So women experience that differently than men. And so women have pain associated with menstruation and et cetera. Women experience pregnancy and childbirth, men do not. And that's also associated with pain, et cetera. So generally speaking, women have more pain that's biological. On top of that, we talk about gender as being a cultural construction. and women, which means gender roles and gender-based violence and things like that. And women experience more gender-based violence than men do. And the consequence of that, or the associations of that, can lead to trauma, PTSD, et cetera. And so we see differences between men and women in terms of prevalence of behavioral health conditions, including mental health conditions. And in part, as a consequence of that, women are, for lack of a better word, more medicated in society. They receive more prescriptions for medications to treat behavioral health conditions, et cetera. So that's one difference.
So when you start putting all of this together, higher rates of prescribing, both biological and psychosocial, cultural differences, what are then the implications for both preventing substance use disorders in women and for treating them? A broad question.
Yeah, so I'll start with the treatment piece. And I think we have to recognize what we call co-occurring disorders. So these are individuals who have a substance use disorder who also have a co-occurring mental health condition. And we have to recognize that among individuals with addiction, they have a higher prevalence or a history of trauma, and sometimes a higher immediate sort of violence in their lives, intimate partner violence, et cetera. So it's important in the context of treatment to screen people for trauma, to ask them, to provide safe spaces, to provide in particular safe spaces for women with histories of trauma. So and that can mean for some, not all, gender separate treatment for a group or things like that. So that's one important piece from treatment. From prevention, one thing I didn't mention in terms of gender differences with substance use is the phenomenon that we call telescoping. And that's we see in women versus men. And that's defined as the time from substance use initiation to the development of problems or the diagnosis of addiction. And that time frame is shortened or telescoped among women. And so women proceed more rapidly from use to misuse to addiction and problematic use. And I think that there's a way to speak that would be part of public health prevention messaging, so that the dangers of initiating substance use differ for lots of different reasons across people, but also by gender.
So, again, obviously, these are very complex topics, either prevention and treatment. Are there resources that clinicians or there may be public health staff beginning to work on these issues at a state or local level? Are there a couple of sort of clearinghouses or good places to go for resources?
I think one of the best at the federal level resources or clearinghouses for information related to gender and addiction has been SAMHSA and the Substance Abuse and Mental Health Services Administration. And they've had many white papers, implementation guides, et cetera, to look at things like bringing what we call sort of gender-informed treatment, looking at screening, looking at things like this.
Dr. Terplan, I think one question which may be in the mind of a lot of clinicians, maybe others as well, is your perspective as a treating clinician on the prescribing of opioids. This has been something that there's been really a great deal of discussion about lately. What is your approach to that issue?
I think we want to acknowledge how we got into this opioid epidemic, which is in part from overprescribing of opioids. But we have to pay attention to where that all came from. And it was individuals coming to their physician with expressions of dis-ease, pain, suffering. I don't feel right. Help me. And I think it's really important as we implement appropriate opioid prescribing guidelines that we don't lose track of the fact of why people come to see us in the first place and what to do about it. And I don't think patients came to the doctor in the early part of this century saying, I want opioids, I want to misuse them, I want, to be exposed to the possibility of developing an addiction. They came saying, I want to be listened to. I want you to hear my hurt and take it seriously. And that's at the core of the doctor-patient relationship in clinical practice. And I think we can't lose sight of that. And we have to think then, well, how do we address somebody's pain? If it's not, giving somebody methadone 3 times a day for 6 months, how do we do it? And some of it, there's a language piece. I think we did a massive disservice by utilizing the term painkiller when we were talking about opioid analgesics. I think it's important to not set expectations unreasonable. So for example, like the goal of therapy shouldn't necessarily be pain-free, but you work with your patient on what the goal is. What is it about the pain that's most interfering with your life? I'd like to be able to, play in the park with my grandchildren, or I'd like to be able to not be, stuck behind the desk at work and be back, being able to do more manual labor. And then you work on that, and you work on those goals. You find reasonable goals that the patient gives you, and work towards that. And then we use a multiplicity of other things: non-pharmacologic management, non-opioid pharmacologic management, and check in. Because that's the other piece of the opioid, prescribing practice, was that we gave opioids, and they don't work that well for chronic pain. But nobody really ever checked back in with the patients to be like, well, how's it going for you? And when you give somebody a medication that doesn't work, all that can happen from that is a side effect. There's no effect. You've ruled out the possibility of benefit, so all that's left to you is harm.
Thank you very much for joining us today, Dr.
Thank you.
Terplan. Please join us next month for Beyond the Data.